Great. Hello, everyone. I'd like to welcome you all to our event on using evidence for empowered and informed practice in pregnancy and parenting. We have a wonderful set of speakers who are going to be joining us in a panel discussion in a little bit to talk about why data-driven approaches are such a critical tool to guide both individual practice as well as broader policies and programs around maternal and child health and childhood development. But before we turn to the panel, I want to invite up our distinguished speaker, Emily Oster, to the podium to share a few remarks reflecting on her two books, Expecting Better, and the more recently published Cribsheet, a data-driven guide to better, more relaxed parenting from birth to preschool. Emily Oster is an award-winning economist and a professor at Brown University, and she's put her expertise to good use to review the evidence around various decisions that people face across their pregnancies, as well as in the early years of parenting. So welcome, Emily.
Okay, so thank you guys all for coming. I'm so excited to be here, and thank you for the introduction. So I thought a lot about sort of how to capture like the feel of my books, and particularly this new book. And so I think for me, I kind of start often with a shared parenting experience. So your baby is 3 weeks old. They just finished eating. They're kind of like asleep, and you're sitting in your bed. It's 3 o'clock in the morning. Your partner's asleep next to you. It's their fault, and they're a jerk. And the question is, you sort of know, like if you just kind of like edge down a little bit and move the baby over, they will stay asleep. And then if you put them in the bassinet like you're supposed to, you know that they will wake up. And so you wonder, like, well, is it okay to just like, how bad would it be to just like edge them down a little bit? And so you get on the internet. And you ask some people on Facebook, hey, is it okay to do this? And immediately you get sort of both sides. First, you get one side. They're like, absolutely. People have been co-sleeping with their babies for millennia. It is the only way to do it. In fact, if you don't do this, you're a bad parent. And then on the other side, if you do this, your baby will die for sure immediately. Okay. Those can't really both be true. And of course, maybe you put your baby down, maybe you don't, but probably you don't leave that interaction feeling like, boy, I was really confident that I made the right choice there. And so in some sense, like the core of what I'm trying to do, particularly with Cribsheet, but also with Expecting Better, is to try to give people a framework to think about those decisions in a way that they can be happy with and they can feel confident with. And that framework kind of starts with data, with looking at what are the risks really. So it is sort of neither true that your baby will die immediately if you put them in the bed next to you, nor is it true that this is a totally risk-free choice. And ultimately, confronting those risks is the first step to making the right decision, but it's not the only step. That you have to both combine that with some idea about your preferences, about what is the things that it's going to work with your family, about how do you think about these risks, and putting those together is the way that people will make decisions that are going to work for them. So I want to say a little bit more about the data part of this, because when you actually sort of try to go into the data on these topics, it isn't always as good as you expect. And I thought for me, sort of pregnancy was kind of the crash course in this, that you got some piece of advice about, you know, you should do this, here's the recommendation. You're like, okay, let me look at what the data is on that. And then it was like, there's one study from 1964, and that's it. That's all the data we have. And oh, that doesn't sound very, very good at all. And so when I had that experience, I sort of kept pushing and pushing and pushing, and ultimately that was the source of the books. And so I thought it was sort of useful to kind of think about data a little bit in three categories with a couple of examples. So I think there are some places in this space where the data really helps us. So like an example of that is vaccines. Okay, we have a ton of data on vaccines. If you want to know the answer to whether vaccines prevent disease, yes. And there's tons of information on the fact that that is true. If you want to know the answer of whether vaccines cause autism, the answer is no. And also, there's just tons of evidence on that. So yes, there are small unanswered questions in pieces of vaccines, but basically that's a place where the data is really good and tells us a very clear story. Then there are other places where the data is really good, but the story is kind of like, it's less clear what the right choice is. So like fish. Okay, should you have fish in pregnancy? What kind of fish? Well, on the one hand, fish contain some omega-3s. Those make your kids smart. On the other hand, fish contain some mercury. Those make your kids stupid. And so you have to trade off. And the data there is very good. Like, we actually really know how much of those things are in fish. I mean, that's something where you can just measure it. You get the fish, you measure how much stuff in it. It's a very knowable thing. But of course, it doesn't say always eat fish, never eat fish. It says you have to think about it. There are some trade-offs there. And then there are places where we just we have to confront that we do not have data. So, okay, Lena, we're talking about one example of this is medications in pregnancy and breastfeeding. I get a million emails from people who are like, I'm on this medication, I'm on this thyroid medication, I'm on this SSRI, I'm on this other stuff. What is the answer to whether I can keep taking this when I'm pregnant or when I'm breastfeeding? And we have almost no data on most medications in terms of are they safe or not safe. The evidence is just not there. We haven't experimented on pregnant women. There's many reasons for that, but the upshot is that you're going to have to make that choice without having the kind of data that we would hope to have in a sort of maybe less fraught but more frequent experience. When you think about early parenting, there's screen time. So is it okay for your baby to watch your iPhone? I don't know. And nobody knows. And so we see there's a lot of advice about don't expose your kids to screens, but actually the evidence behind that isn't very complete, in part because how would you know what the impact of having your 2-year-old play apps is on whether they will graduate from high school? The kids who are graduating from high school now, they did not have apps when they were 2. And so as these things evolve so quickly, there's a limit to what we can know from data in those cases. And ultimately, some of those kind of choices we're going to have to make without data. So I think by kind of putting these in these categories, maybe we clarify a little bit both what kind of additional data we have, and I'm hoping we can talk a little bit about that in the panel, but also where the data sort of does tell us what to do. So two sort of final thoughts before we start with our exciting panel. So one of the things that I think is worth reflecting on, that I spend a lot of time on in thinking about, at least in both books, is that a lot of these choices in pregnancy and parenting, I think, should reflect to some extent the needs of the parents in a way that they're often not in some of our rhetoric. So in the new book, I talk about the choice of whether to work or not, and that is almost always framed as whether both parents should work or one parent should stay home, and it's often framed as what's best for the kid. And the answer on what's best for the kid is there are a lot of good choices, and there isn't any evidence to suggest that it's particularly better or worse to have a working parent, 2 working parents, or one stay-at-home parent. So actually, when your family comes to make that choice, a big question should be: do you want to work? Do both parents want to work? Is that something that you want to do? So I say this to people, and a number of people have told me, "Wow, I never thought about that. I never thought about whether I wanted to work. That wasn't ever part of the calculus that I would have." And in some sense, that seems crazy. You're going to do this every day for your whole life. For 40 years, 9 hours a day, you're going to be at your job. You didn't think about whether that's something that you want. And I think we've gotten so much into this idea that well, if it's good for the baby, okay, but it could also kind of ask if it's good for you, because parents are also people. Message. And I think the second big theme of these books is that when we should use evidence to try to sort through noise and advice. And I think there is sometimes a feeling when we make policies that we don't always want to explain to people why. We just want to tell them okay, this is the thing you should do. But I think when we don't tell people why we are making that policy, it makes it sometimes hard for them to trust us. And so I think we should be a little bit less resistant to explaining what the evidence supports and to admitting when the evidence is more limited, and to hope that people will take that evidence where it is and make the right choices for them based on data. That's what I would like. So with that, maybe we can all come up and have a panel.
So thanks for getting us off to such a great start, Emily. I'd like to introduce our 2 other panelists who are joining us. So we have Dr. Lisa Noguchi, who is the Director of Maternal Newborn Health at JPIGO, the Global Health Implementation Arm of Johns Hopkins. She's previously served as Maternal Health Advisor and Zika Response Team Lead at USAID's flagship Maternal and Child Survival Program. And she also has degrees in anthropology and nursing and nurse midwifery, as well as infectious disease epidemiology. Dr. Noguchi has over 20 years of experience in clinical practice, research, and program implementation in the US, Africa, Latin America, and the Caribbean, and Asia. So welcome, Lisa, to the panel. And then to her right, we have Pooja Shripad, an associate at Pop Council, who has a PhD in international health systems, also at Johns Hopkins. And she's a social science researcher who focuses at the intersection of women's health and rights, with experience in Africa, South Asia, and Latin America. So Pooja's work has specialized in using qualitative and mixed method studies with a particular focus on trust and socio-political relationships as they relate to maternal care. So welcome. I think Emily really got us off to a great start thinking about how evidence can be used in the context of individual decisions to make sense of all of the noise and to better understand how to navigate a very complex decision space across pregnancies, across many, many parenting decisions that come up, especially early in your child's life. But I want to bring in Lisa and Pooja to the conversation as well, and kind of expand the focus not just from sort of the US and individual level context, but thinking more globally about the role of evidence, the role of data-driven decisions on women and on programs across the globe. And if you could each reflect a little bit about the kinds of evidence that you found to be the most critical in some of the work that you've led, whether it's on vaccines or around infectious disease outbreaks, or Pooja, in your experience around eclampsia and childbirth experiences. So maybe just sort of reflecting on how evidence has played a role in the work that you've done.
Sure, thanks. And thanks so much for this opportunity. I'm very happy to be here with this panel, especially. You know, I think parents in the low resource settings where we work face these same sort of challenges and trying to figure out what the best choices are. Pregnant women, breastfeeding women in general don't have as much data about their choices as other women and men do. And I can think of some examples, especially in sub-Saharan Africa and malaria endemic areas where malaria still is responsible for a lot of maternal deaths, still responsible for a lot of newborn deaths. And there's a global recommendation for women to take certain medications during their pregnancy, the beginning of the second trimester, and continue those. But women don't feel comfortable actually taking the medication always, and so we tend to have very poor coverage of that medication. And it's probably due to, in many cases, the lack of a trusting relationship with a provider. And so not having a trusted provider, a healthcare professional with whom they have a relationship where they're going to believe the evidence, receive the evidence, have enough time to hear counseling, is created some real gaps in use of data-driven choices in pregnancy. I think we have situations where often healthcare professionals don't have a whole lot of time to do counseling about the evidence, and that means that translation of evidence to practice is especially challenging. You might only have, an average woman might only have 90 seconds of counseling during prenatal care throughout her entire pregnancy in a low resource setting, or a 3 to 5 minute antenatal care visit. And it's almost impossible to really have that good interchange between provider and client.
So Pooja, I know that Lisa touched on trust, and that's a big area of yours, but if you wanted to reflect on sort of how data and evidence-driven approaches have played out in the settings that you've worked in trying to deliver maternal care.
Sure, and thanks again for having me on this panel. So I guess for me, I was thinking a little bit about, I definitely agree that trusting relationships, actually just recently, the White Ribbon Alliance did a global campaign that asked the question, what women want? And it actually looked across a range of countries. And the first, sort of the most important thing that people mentioned was respectful and dignified care during childbirth. So I think that speaks to this idea of developing positive relationships with your providers, whoever those may be, in low resource settings. So I think there's the issue of having a primary care provider or somebody who can give you antenatal care, there's also community health workers in these contexts that play a very important sort of intermediary role. And we've looked a little bit at that under the Ending Eclampsia project, so thinking about strategies to build awareness at the community level, access to information that isn't always there, the internet at their fingertips, those kinds of things, to look at different ways in which women get their information. So sources may be their partners, their community leaders, their church members, also radio spots, other kind of NGO and other civil society plays a big role. So thinking about different sources of information is, I think, really important. And one thing just to note that in terms of the types of information that might be important for policy and programming, sort of distinct from the individual, is that there is evidence from demographic health surveys that show if women are empowered in different areas of their life, they are more likely to seek and use antenatal care, maternity, deliver at a facility, as well as postnatal care. So I think it's important to keep track and sort of be cognizant of kind of what that means for each country and their policies.
Great, thanks. So it's interesting because I think that there's a couple themes that have come up. So one is, what kind of evidence do we actually have to inform practice? And there are some things where it's very good, like vaccines, or potentially, having access to institutional delivery, particularly for complicated labor and deliveries. But then there's this whole other piece of it, which is knowledge translation and knowledge brokers, and having enough to actually go from what we know is actually good to practice. And maybe each of you could kind of reflect on the role of different types of knowledge brokers, and potentially some sort of key takeaways from the work that you've done on how we can use where we do have good evidence to actually translate that into beneficial practice and more empowered decision making.
Yeah, I mean, I think that part of what is great about sort of parenting now is that there is a lot of information. That is also part of what is really bad, which is, there's always, like studies show, okay, there's always a study that shows something. And I think that when we are sort of like getting like the possibility to look at 3 o'clock in the morning to find out like whether green poop is like good or not for your baby, like it's great to be able to get on the internet and have other people be like, yeah, my kid's poop is also green. But then also you will find the thing, it's like, that could be something terrible. Studies show that sometimes. And so I think we kind of, how do you, there is a piece of this that is kind of almost the responsibility of the media or whoever is putting things on the internet, media, to try to help people be more informed consumers of the evidence that comes out. And to help people see, okay, yes, studies show, but not every study is as compelling as every other one. And sort of pushing statistical literacy, I think, is a challenge in these places, but something that we should all try to do if we are trying to communicate. But I think that is a real challenge, because you even within the space of experts, you will get people who say one thing and say another thing. And when I think about things like the anti-vaccination kind of movement, you have people who you can watch a debate about vaccines between 2 old white men who look exactly the same. One of whom is saying, I am an expert, I am a doctor, vaccines are safe, and one of whom is saying, I am an expert, I am a doctor, and I'm very concerned about vaccines. And unless you are like reading the evidence for yourself, how do you know which of those people to trust? And I think that's really hard.
So in some of our work recently in Kenya and Nigeria, we've actually started working with group-based antenatal care as a way for women to really talk through their questions about recommendations in pregnancy. So, when we talk about things like worrying about coffee or worrying about having a drink while you're pregnant, when a lot of times when you step back, risk to women globally, violence is a big risk to women in pregnancy. Traffic accidents are a big risk for women in pregnancy, but we do tend to worry a lot about these small lifestyle choices, which is very understandable. But in the group context, you get the chance to sort of talk through some of your questions, and with a nurse facilitator or a midwife facilitator, actually talk about what the evidence says and what the recommendation is in a way that's not threatening, it's not judgmental, it allows for questions. And we found greater uptake of health interventions in pregnancy from that approach. We're still learning about the limits of that model and how best to implement it, but it seems to be a pretty promising way. It's been used around the world in different contexts. So.
And sorry, just to ask a follow-up on that, has there been instances where misinformation has kind of come into that?
Absolutely.
And how does that play out in that group setting versus potentially in other ways that you might try to navigate through, the rumors or, the old wives' tales or whatever it is that also kind of seeps into this space?
Sure. I mean, it comes up. I think there are, just like vaccination, family planning has been plagued with lots of myths and misconceptions, contraception. And so, someone in a group might say, I've heard that the intrauterine device can get lost in your body, and then what will happen? When in reality, most of the time, the IUD will stay in your uterus. It will do its job. It's safe and effective for preventing pregnancy and spacing pregnancies. So, in that situation where somebody brings up a concern, the facilitator is trained to say, has anybody else heard this before? What have you heard about the IUD? What have you heard? And then talk through what the evidence says, but really allowing women a safe space to have their questions and concerns brought up and respected and addressed, and not feel like they're being, pushed aside or talked down to.
Well, actually, it's interesting to hear because we're also doing similar work in Nigeria and Pakistan on Group A and C, and I think that is a really great model for just building more of a social support network that's often necessary for women to reach care in these contexts where they're often not the primary decision maker, nor do they have the ability, capacity to get to services. To add on to that a little bit, just thinking about other community strategies that we've seen, is including men in the conversation beyond just women. So engaging them about discussions around their partner's childbirth experience. For example, in Kenya, we did a study at the Council on respectful maternity care, and so really engaging. It was sort of this whole participatory process that we used to collect data, information, and then have communities reflect on that information and co-develop a strategy to address that. And so one of the strategies is having these community dialogues that really get people who maybe aren't used to talking about what a care interaction should look like, to express what they feel in an ideal world it would look like, and to reflect on some of these basic human rights that are, or maternal and human rights that need to be met.
So I think these are really great models for how to transmit the evidence and the practice and the information that we have. But I also know that particularly pregnancy and early childhood child rearing is plagued by real gaps in the evidence base. And I wondered if each of you, in the work that you've been doing, if you had your wish list of the biggest evidence gaps that you wish there was just more data to inform practice, to inform choice, what would be the things that you would want to have that kind of evidence on?
I mean, there are a lot of problems with data on pregnancy. A lot of things I would always want more evidence. I mean, I think in some ways for me the gaps fall in the places where that are most salient to new parents, like sleep. Like, I still think we don't understand enough about, like, sort of safe sleep environments, the set of sleep environments that we should have, how large are the trade-offs across sleep environments, and what are the, almost what are the ways that we can support parents, like, to make it possible to have safe sleep environments while also, like, actually sleeping. I think that sometimes there's a sense that it's sort of like, here are all the things you should do. It is literally impossible to do those things. Like with my second kid, like, he would just only sleep if you were holding him. That was it. He was like 2 weeks old. You just hold him. He'd sleep for 12 hours in a row. You put him down. He'd wake up in 14 seconds. I mean, like, every single time. And it was just like, at some point, you're like, what can I do? Like I don't want to, go against these recommendations. But I literally don't know what I can do. I literally have no idea what I'm supposed to be doing. And I think that I think there are ways for research to inform those kind of trade-offs. And I think part of what's hard is that those kind of things happen not in a hospital setting, not in a, and you also, they happen in your house at 3 o'clock in the morning, and then you forget them. You're by the time your kid is 6 months old, and they're say they're sleeping for 5 hours at a time, you don't remember what it was like even then. Forget about it. Now my kid's 4. I'm like, what? I'm sure it was fine. I should have just put him, I'm thinking now, why didn't I just put him down? I'm sure that it was fine. But of course that's not the way it is at the time. And so I think that's, for me, that is one place that we could do more.
I think at the top of my wish list is if I could have a way to prevent and predict preterm birth. Preterm birth is still a major cause of newborn death globally. Same thing goes for preeclampsia and eclampsia. If we had a much better sense of how to prevent preeclampsia and eclampsia and how to predict who is going to develop it, we could avoid all sorts of adverse maternal and newborn outcomes. And I think there's, sadly, a lot of misinformation out there about you should do this, you shouldn't do that, you can't lift that box, like Emily's saying, because of you might cause preterm delivery. Exactly.
It might fall out.
It might fall out. But reality is that when we have these evidence gaps, like we're bringing up here, people tend to fill those with something. They fill them with some information, a narrative that really has more to do with cultural norms and gender norms than it has to do with evidence. And those the way of framing those things tend to adversely and disproportionately affect women and judge women for their choices around things like, I saw this woman at Starbucks and she was pregnant. She got some coffee and she really shouldn't have, I think that made the news, because of a conflict between a barista and a pregnant woman, when in reality we need to stop judging the pregnant woman for her coffee and start judging our healthcare systems for institutional racism that leads to many more problems with maternal mortality than coffee. Yeah,
probably doesn't lead to anything.
So yeah, I guess one thing that I was thinking about as you were talking about what to do in a real world setting when you're actually in, have to make a decision, I was thinking that one area that we do need a little bit more on is just implementation research, implementation science approaches that look a little bit more at real life settings and how to make decisions, not necessarily for your own care, but also from sort of a health systems level, what could be done at the facility level for providers to make sure they're aware of what to tell their patients. Because I often find, from what I can hear, at least from low and middle income country settings, is that there's a knowledge gap there too. So I think that's one thing. The other thing that I actually think we need to understand better is some of these norms, actually. I think we need to do a little bit more work around understanding experience of care very seriously, and not just saying, were you satisfied, were you dissatisfied, but to kind of really break down what that means to different people and what quality looks like, because I think there's a huge gap there. And then the other piece is to again, be more rigorous about understanding the social dynamics that are happening and how information is being shared and what information is being retained and affects behavior. And I think that can be done through social network analysis and qualitative methods that can really pull out experiences of women from women's voices themselves. So I think those types of methods can really help to draw out groups that maybe are not the ones that that are often researched or get captured in these larger surveys.
I think something that comes up here is so thinking about something like C-sections, right? So the C-section rates vary hugely across space, and for reasons that I think we don't really understand, and some of it is clearly about patient choice, and some of it is about doctor choice, and some of it about health systems, and some of it's about, and I think that always has struck me as a place where we're kind of missing some quantitative data, we're missing data, but we're also missing some qualitative we're missing the qualitative piece also to understand, we know that women are choosing this. So what is making them choose that? What is the information that they have that makes them think that that's something that they should choose? And if we don't think it's what they should choose, how do we kind of communicate that? I mean, that feels to me like a pretty open place we don't totally understand.
Yeah, I think that really nicely highlights sort of the complementarity of the quantitative data of understanding, where there's a new phenomenon or where there's a practice that's happening, and then the qualitative, which really can get at the why is this happening, or what are the views of these women that's leading to this choice or to, this behavior that may not actually be a choice that may be kind of put on them by other people. I know certainly in my own work we found that mix of sort of qualitative and quantitative data to really help bridge that gap around vaccination in pregnancy, around participation in research in pregnancy. And yeah, Lisa, do you want to say anything else about like mixed methods or the ways that different types of data can kind of feed into having a fuller picture of?
I think science has understandably elevated the randomized controlled trial as the gold standard of evidence. But when it comes down to it, there are some things about which randomized controlled trials will never occur. We're never going to have a randomized trial that randomizes women to what if you have one drink during pregnancy versus what if you have no drinks during pregnancy. It's just never going to happen. So we rely on observational studies that do have some bias. RCTs can have bias too. And it's all about whether or not the study was implemented with quality, whether the analysis was done with quality. And that's sometimes a hard thing to translate to mass media. And so science communication, I think, going forward, as people get more access to information on the internet, is going to become, quality of science communication is only going to become more important.
Yeah. So I wanted to pick up also on something you said earlier about how the evidence gaps lead to people just filling it with stuff. And this is something that I've also kind of termed dogma versus data. And maybe each of you could reflect. I know you shared the story about the women's group and the IUD and some of the misconceptions, but maybe each of you could talk a little bit about your experience coming across something where the dogma or the conventional wisdom was X, but then when you actually look at what the data says, it just either doesn't hold up at all or it could actually be harmful, which I think isn't often talked about. And maybe there are some examples from your work where the conventional wisdom didn't pan out, or where the dogma was maybe the wrong way to go.
It's interesting. I know I got these questions before, and then I couldn't think of anything. So I just decided I would think about it when it came up, but I still haven't come up with anything. I think that there are a bunch of places where we kind of give people the impression that some piece of sort of dogma is based on evidence where it's not. And so one of them that always comes to mind is like the order that you introduce foods to your kid, that like you should give them rice cereal first, which is like in the US is like this sort of like very standard. That's like you start with rice cereal and then you give them these vegetables every 3 days, and it's like this sort of very precise thing that everyone's told. And I just sort of assumed like there was a reason for that, but of course actually that's like there's nothing wrong with that. It's just like totally made up. There's no reason you have to do that. In other countries they don't. That nobody starts with rice cereal. It's just made up. And so that's fine. Then there are of course places where we see we have some conventional wisdom which does turn out to be totally wrong. And so the one I talk about a lot in the book is about allergens. So the sort of conventional wisdom, like advice that parents have been getting for a number of years, is that you need to wait to introduce allergens. So like wait to give your kid peanuts, because if you give them peanuts too early, they will become allergic. And so when my daughter was born in 2011, like that was the advice that you guys like wait, peanuts are like maybe a year, maybe 2. Like you want to wait to give them the peanuts. That turns out to be literally the opposite of the right advice. And so there was and this is something where like the evidence changed. We all of a sudden got a large, very, very convincing randomized trial which showed that if you give people peanuts early, like, as soon as you are giving them food, possibly before, that actually prevents allergens. And the effects there, this is one of the very few places where the evidence is really good and the effects are huge. Like most things in this space, it doesn't matter. Just most things like the effect sizes we're looking for are small. And this is the thing where there's like an 80% reduction in the risk of peanut allergies from giving kids peanuts at 4 months rather than waiting for a year. So that was a place where the conventional wisdom was wrong. It is like the reason that I cannot pack my kid peanut butter and jelly sandwiches for lunch, because all of these people got this advice and now everybody has a peanut allergy, which is of course not their fault, but has been sort of somewhat damaging. For me personally, also other people have been damaged. I will admit I am not the main person who is suffering from this advice.
I think when I think about low resource settings where I've worked, I've worked with health professionals who were trained to err on the side of treating with antibiotics, after delivery, in settings where episiotomies or cuts were done routinely to, the conventional wisdom in this particular setting where I'm thinking about was that, this will speed delivery, it's easier to repair, and then all these women should also get 2 weeks of antibiotics, which is not evidence-based, and is likely contributing to antimicrobial resistance, which is it's already a problem, and it's going to be on the horizon as an even bigger problem. And I think we're just starting to get some of those antimicrobial resistance messages out to health systems and lower and middle income countries that, where there's just a disconnect between more antibiotics are good and the evidence around use of antibiotics.
When I was thinking about this, again, there's a lot of misconceptions and myths around pregnancy, and particularly I was thinking about eclampsia. There's, in some of our work in Ethiopia and Nigeria and a few other countries, we hear quite a bit about witchcraft and supernatural causes of these eclamptic shocks, or even some of the symptoms that come up like blurry vision and things like that that are signs of preeclampsia. And so sometimes these often just delay people. They're not really sure what it is. They seek alternative sources of medicine, which sometimes it's not actually harmful. It might just be sort of a delay and going to a church leader or a traditional healer who gives like prayers or something like that. And in some cases, it might actually cause harm where things are given that might be elevating or is exacerbating some of the symptoms. And then there's that issue, as well as the just delay culture of sort of hiding one's pregnancy for as long as possible, which also just delays and kind of goes in contradiction to some of the guidelines that WHO has put out about ANC visits and things like that. And so I think it's a bit of a challenge, and there's strategies that are being explored right now in terms of trying to promote antenatal care and early antenatal care and things like that, but I think there's still a long way to go.
I mean, I think there's this general issue, which is that, as you said, when we don't have an explanation, we don't understand why this happens. Mm-hmm. You want there to be an explanation. I think this comes up in, it's witchcraft, but it comes up in autism and vaccines, and it comes up in all these places that, like, when there is something that happens that we don't understand, we want to fill it in with something that feels causal or that seems like an explanation. I think that is like a very natural human instinct, which particularly becomes problematic in these places where we don't have actual explanations for stuff.
So what would you say are the key challenges in terms of really getting toward adoption of evidence-based approaches, or even evidence-based recommendations? Because I think it's not just even at the individual level. I think there's a lot of recommendations out there that really are kind of coming from just a historical precedent, or maybe don't have the right kinds of data behind them. So yeah, what do you see as sort of those key challenges towards moving towards this approach, and maybe some potential solutions? I know we've touched a little bit on some.
I think, Carly, you know what I'm going to say. No, because Carly and I have been working together. We're in the same space for years around the need for better quality and more research on medications and pregnancy and breastfeeding, but especially pregnancy. We have these big data gaps where medications get approved never having been studied in pregnancy, but they're going to end up getting used in pregnancy because unplanned pregnancy does happen. And sometimes people are taking medications and they become pregnant, or they need to be treated, and that's the option that they have when they're pregnant, is a particular medication, and so it may get used in an evidence gap. And so it's really critical that funding continues and increases for the study of medications in pregnancy for a whole host of uses. So.
Yeah, just picking up a little bit on that, is the chair's prerogative. Emily and I were just having a conversation earlier as well about sort of this misconception that it's unethical to do research with pregnant women. And it's been something really interesting to hear I feel like the narrative has really shifted over the past few years that, okay, well, of course you couldn't test something in pregnancy. That would be unethical. But I think people have become much more aware that these data gaps have real harms because, again, then you have people either using things in pregnancy without knowing the right dosing or knowing if it's actually safe, or people not using things that they should be using in pregnancy, not managing. Sorry, I think my hair has interfered. And I think that's also one thing that, I mean, from my own perspective, kind of shifting the narrative or tackling some of the dogma around, well, evidence generation around pregnancy, like we just don't do that. That would be unethical, to sort of saying, no, it's actually unethical not to do it because we need this data. So sorry to jump in there.
Yeah,
but
no, and I think it
point.
extends to situations where we have some evidence, but maybe not as much evidence as we would like. Something that's come up in the HIV world recently is a concern that a particular antiretroviral drug may be associated with a particular type of defect in pregnancy, neural tube defect. And there was a big outcry from activists in Africa that said, we need access to this medication, dolutegravir, because it works really well, and let us decide whether or not to take it.
I mean, I think that is the thing that is, I think, in many of these cases missing, is we have this idea that recommendations have to be like do X or don't do X, as opposed to like here are the benefits of X, here are the risks of X. Like, generally we would recommend that you do the following, as opposed to sort of like having every recommendation be do this or don't do this without sort of talking about how strong is that recommendation, because I think you kind of lose people if you just have everything be like you have to, everything, it has to be this way, and people are like, well, I'm not going to do that one thing you said, so why would I do all the other things? But some of the other things are really important, and that thing maybe wasn't important. So I just think we need to move to nuance. There needs to be more nuance.
And I think that's hard in situations where you don't have providers who are trained with counseling skills, or you don't have enough time built into your health system where you can actually have a conversation with a health professional.
Which is a problem in the U.S. also.
It's a problem everywhere.
Yeah, no, that's a problem everywhere. I think one of the things here is, I think this is where qualitative data, just to plug it more, I think can be really useful because I think it gives at least a way to parse out narratives of, say, do this or do that, or this is the effect if you do this or do that, but you could also tease out if you do this in this way, recognizing that the X, Y, and Z could be factors in that affect why you do this in this way. That's the kind of narrative that I think can maybe provide a little bit more direction to policymakers. And I think from my experience, just translating some of these ideas to regional level or district level health management teams in various African countries, it's this combination of what is it, what's the practice, but also how can we build it in to our health system, whether that's at the level of a community health unit or whether that's a level of a health facility, or kind of delineating who can do what and the types of information that you can give. But it is more of a systems approach that I think you have to take in order to get this data used.
Yeah, and I think also this talk about nuance and sort of looking at both sides of the coin is that very often it seems like you only focus on the benefit of doing X or on the risk of doing Y, rather than kind of looking at a more holistic, balanced picture of the benefits and risks of both, and potentially across not just the child, but across the family unit, across the maternal fetal dyad, which seems to be missing from a lot of the conversation. I mean, even in the context of the example you raised, Lisa, about dolutegravir. So again, it's both a case of not necessarily looking at the benefit side of it, of a much better antiretroviral that would, virally suppress, lower toxicity, and this is something women could use over their lifetime, with a signal that we didn't know and still don't know if it's real. But it's also a case of, a little bit of data can do a lot of harm. And this is sort of that example of like, if you cherry pick one study, well, this studies say, but usually it's just that one study that shows something, and maybe the effect size is statistically significant, but that's sort of what gets translated to the media. So I think there's this double-edged sort of a little bit of data that's not enough to actually draw meaningful conclusions, but also this kind of lack of nuance of looking across holistically, the benefits, the burdens, the potential harms to all the parties that are involved and affected by these decisions. I think that's really nice.
This came up a lot in the Zika outbreak in the Americas in the past few years, where it's, I think people in high resource settings, low resource settings had to think about, like, what does this mean for my pregnancy? What does this mean for planning my pregnancy? And the evidence was literally being generated every day. And some of the evidence, now that the outbreak has already gone down, you can see the number of papers is still like really high, actually, compared to the number of cases of Zika. But families didn't necessarily have good decisions, good evidence on which to base decisions about travel or about protecting their pregnancies, or the options that they were faced with weren't that great. It's really, in many settings, it's very difficult, because we know that Zika is sexually transmitted. Mm-hmm. It's very difficult for women to negotiate condom use with their husbands while they're pregnant. So it's become a challenge, I think, across a range of settings.
Yeah. Yeah, and I think I'm just remembering too, when the WHO recommendation came out, before there were any countermeasures, and we still don't really have great ones that are fully evidence-based, but the recommendation was delay pregnancy. And the regions, like talking about the real-world settings and the implementation science piece of this, the settings in which that recommendation was meant to apply was very Catholic areas where lack of access to family planning options was very prevalent. It was really difficult, and these kind of interpersonal dynamics of having to negotiate use of family planning options is not always necessarily within the realm of reality for these women, which in turn then it's like, oh, well, you got pregnant during a Zika outbreak. Like, where does the blame fall then if the recommendation is, well, you weren't supposed to get pregnant? Sorry, I was having a flashback to that. So I want to make sure that there's plenty of time for Q&A, since we have such a wonderful audience here and many people brought their kids, and thank you for doing that. But before we do that, I thought maybe we could just wrap up with 1 to 2 key takeaways that you most want the people in the audience to walk away from this discussion and kind of have resonating in their heads as they leave.
I mean, I always say the same thing, which is like, other people's choices are not your choices. I mean, I think part of what makes kind of modern, like upper middle class parenting a little stressful for people at the moment is that, there is a lot of there is a lot of advice from a lot of different angles, and so you get the barista wants to tell you what to do, but so does your mother-in-law, and so does the lady who lives down the street, and so does that woman in the park, and your best friend, and sort of it is easy to feel that you're making a mistake, and you're probably making a lot of mistakes. We're all making many mistakes. But thinking carefully about these choices and then making the choices that are right to you, but sort of recognizing that preferences are super, super important, that data is great, but it usually doesn't give us the answer. Usually you need to think about what works, and that means two different people will make 2 different choices, even with the same data. I think that's something that we've been missing in a lot of these conversations.
Yeah, I agree. I would say the more that you can find a health professional that you trust to have a real conversation with about choices, and when you have questions, the better. Having the opportunity to talk through concerns and having a good listening ear and someone who can help translate the evidence, because there's so much of it, and some of it is good and some of it is terrible. So having someone to help you translate that information and knowing what sources to trust when you can't get a hold of them is really critical.
Yeah, so I was going to talk about knowledge translation, just kind of thinking about the importance of finding the right broker there, but also just that we need much more research in this area too. And I think that how to engage these knowledge brokers, whoever they are, is part of it. I also think just any implementation research should really focus on other actors around a woman, because I think there's often a focus on a woman making this decision and she feels like she has to make it on her own, but in many settings that's not the reality. And so thinking about how those other actors, whether spouses, mother-in-laws, friends, family, etc., are involved is a key part of it.
I think, I'm sorry, I'm going to throw one more in, Carly, sorry. One more thing to think about is, we're talking about the sort of pressure that parents put on themselves, especially women, And I think we need to step back and think about what's going on here, that women do need to feel like they need to be the perfect pregnant lady and the perfect parent, and really thinking about, like you said, individually owning your choices and what you're comfortable with, what level of risk. Everyone has a different threshold in terms of acceptable risk, and feeling comfortable with the unknown. And working through that is really an important part of becoming a parent. And learning to trust your gut early on while you're digesting the evidence is an important part of becoming a parent, I think.
Well, that's the perfect segue to open up the floor for questions. So I think we'll take 3 at a time, and then let everybody answer, and then take a few more. So, okay, great. I see 1, 2, 3.
Hi, so the talk about...
Please introduce yourself.
Oh, sorry. Hi, everyone. I'm Aditi. I just moved to DC to start a summer internship at Evidence Action. So the discussion on whether or not conventional wisdom is evidence-backed got me thinking about the role of the maternal grandmother. Now, I can only speak for India and South Asia, but during pregnancy, most women move to their parents' house, and the maternal grandmother really plays an important role both before and right after the pregnancy. And typically, it's when the child is somewhat older that you move back to your husband's house. So I was wondering 2 things. One is, all of this conventional wisdom that comes from the maternal grandmother, A, is it evidence-based? I'm thinking of my own grandmother, for instance. And B, like when you're thinking of, community-based interventions, should we also be targeting the older women in the household? Because especially the younger mothers, they really look up to these women in kind of their decision-making. So I was just wondering your thoughts on that.
Okay, great. Let's take 2 more, and then... So there was one up here and one right over there.
Thank you. Hi, my name is Alexandra Over, and I'm a first-year medical student. So I was going to ask about what you guys think the role of and the responsibility of the doctor is in making these decisions, since a lot of the policies that are frustratingly, black and white, A or B, were put in place originally to try to make those decisions faster and more economical on time for doctors who are tight on resources in many ways. How do you think doctors can help parents, mothers make those decisions, but also still make time for as many patients as they need to in low resource settings?
Okay, great. And then there was one more question up front. You can get the mic.
I can also speak out loud.
Okay, I think we're webcasting, so it's better to get on the mic. Thank you.
Hi there, my name is Hannah. I work at the Canadian Embassy in the Department of Aid and Development. My question concerns on data accessibility within communities that are progressively getting more utility to internet. I lived in Tanzania for 4 years, and we saw the progression of internet there. But how do we make data accessible and in a sense where small communities and rural communities can also sort of start using this, and how do we demonstrate data in what you discuss qualitatively that's also applicable to them in a way that is simplified and that they can also use with having that knowledge deficit? So how do we use North American research and be able to apply it within the developing world?
Okay, great, thanks. So should we go in order? I guess we can start with the role of maternal grandmother or other family members that are really part of the decision-making architecture for a lot of women, and maybe the 2 of you can reflect on some of the community-based work that you've done.
Sure. I think absolutely yes, that people who are the critical decision makers or influencers of women should be involved in any strategy that's being, any community-based strategy. So, and I think it's different in different settings, but thinking about what educational programs or ways in which information reaches those groups is important. So it's hard to give a blanket statement, but I think, for example, with men, we just were able to convene, this was more for the respectful care work that we were involved with, but we had male groups. And similarly, mothers-in-law were also, I think, a group as well. So I think it's crucial to kind of include them in any of those activities.
I will say I think that one place this sort of, when we think about the part of your question was like how much should like is that a good thing or not, like not a good. I mean, I think there are times in which sort of recommendations change a lot, and that I think that is it. Then it can be very critical to reach that population so they know that they also know the new recommendation. You don't end up with in a sort of recent context, this has come up in a lot in the U.S. is like sleep position. So basically, the recommendation when I was a baby was that babies should sleep on their stomach, and the recommendation now is that they should sleep on their back. And I think that if that it is certainly the case that there are a lot of interactions between people and their parents. We're like, why don't you just have them sleep on their stomach? That worked fine. You survived, didn't you? And I literally had that interaction. And so I think that making sure that we sort of communicate those particularly sort of larger changes like that, where actually we think that we have learned something new and that people should be doing something different. I think that can be pretty important to try to dial down some of those conflicts.
Yeah, I mean, I think that sometimes our maternal grandmothers come up with some fantastic advice, like rest. Do you have a baby?
Yeah.
It's interesting how so many cultures say wait 6 weeks or 40 días, 40 days before you have intercourse again. It actually cuts across many different cultures, and that probably gives the uterus a chance to, involution to happen and things to heal and rest and da da da. So that I think that sometimes the advice actually syncs with the evidence that we have. And sometimes it doesn't. Sometimes we have family members pushing babies to start solid foods really early in settings where we don't have clean water and we don't have safe access to food, supplementary foods for infants. And providing those too early increases risk of severe diarrheal disease, which can kill a baby in many settings. So it's a real hodgepodge. It's a mix. And so I think, like was said, we do need to engage family members, maternal grandmothers in these conversations around what's important to know in parenting decisions.
So I think the next question was about the role of the clinician or of the doctor, and how they can do more or better or be those knowledge brokers, especially given some of the pressures on their time.
Yeah, I think it's hard. I mean, I have had a lot of very good doctors and then some less good doctors in terms of sort of communicating risks. And I think part of what is hard in this setting is you have a limited amount of time and your patients need really different things. And sometimes people just want to be told, look, this is what you're supposed to do. And sometimes people want to understand, well, exactly why, and tell me all the evidence and how much more time do you have, because I have a problem with that randomized trial, and here is the way I think that that's not working out. And I think that sort of managing that is a challenge. I think that there is too often, the sort of one thing that is missing is that there's too often a desire by doctors to say that they know everything and to sort of just not convey uncertainty and not convey either I don't know. Maybe there's evidence on that, but I don't know. I got to go read up to date, excuse me. Or I don't, or we don't know. I'm sorry, this is what I can tell you. We don't know. And I think that there needs to be more of a kind of embracing of just the fact that there is not some secret magical fairy dust that you get hit with when you become a doctor that tells you the answer to all the questions. It's okay to not know. Most of the time we don't. And it would be great, right? Yeah, they're still working on that. It's in randomized trials now. But I think that that's something that I think is sometimes missing.
Yeah, I think there's a role for professional societies to help physicians digest the huge volume of data that's being generated every day, and help to translate not just for the public, but for clinicians who need to understand such an enormous volume of data so that they're able to relay key messages in the short amount of time that they had. I'm not doing prenatal visits every day for my patients anymore, but back when I was, a good day was if I only saw 15 to 20, I felt like I really have time to talk to people, answer their questions. But in a day where someone tried to squeeze 30 patients into my schedule, it was really, really hard. And I ended up saying, please call me back. If we didn't have a chance to go over everything that you wanted to talk about, I'm still going to be here. But I'd get home really late and, admit coming home later to my baby, actually, too, then. And it's not really fair for us to always push physicians or midwives or nurses to, spend more and more time with their clients and not really account for how that impacts the health system or their lifestyle. So.
Yeah, and I would say I think one thing that I've noted in my work is that just the providers themselves, there's hierarchies all around us. So, and the health system is a very, very, it's very hierarchical, and that applies across settings in the U.S., elsewhere. So just, I think it's important to kind of, one thing from a system perspective is important to have more of a dialogue between, open dialogue between different health worker levels to kind of make sure, this balance of workload versus how much time you can spend with a patient is really kind of addressed systematically, because I think that often has implications for how providers treat patients, and we've seen that across settings. And so I think the best, I would say, is if you can try to, I'm just thinking from a provider perspective, maybe just to kind of try to ensure as much of an open dialogue with supervisors, with co-workers, as well as from the patients, as be aware of whether or not a patient is going to be able to actually ask you the questions they want to ask. That's a huge challenge in places where doctors are supposed to know everything, and there's less of a precedent for people to question authority. And so just being very clear about who you're treating and the dynamics that could be going on there.
Yeah, I mean, one other thing, just reflecting on this question, I feel so much for providers, especially when they're trying to manage all of their caseload and their patient load. But also given that, this issue around medications in pregnancy, we have so little data, and there's so little out there to guide it. And I don't know if you've ever looked at the back of a pill bottle, but essentially, rather than sort of having the evidence and requiring it through a regulatory system to say, well, we need to actually have answers about safety, dosing, et cetera, it says, consult your doctor before using this. And so it essentially puts not only that pressure of whatever the decision and the discussion is on physicians, but it also means that the liability falls there as well. That rather than the manufacturers being obligated to say, yes, we need to actually study this and know whether or not our product is safe and effective and how it should be used, and there's probably no space in medicine that is more litigious than obstetrics and gynecology. So I mean, I think that is a huge challenge, and it's not the doctor's fault. It's really a systemic failure to generate the kind of evidence that they would have in many other areas of medicine that people practice, where there is actually sufficient evidence to say, here's the evidence and here's what we would recommend based on that evidence. All right, so there was one more question from this round on data accessibility, and as there's greater access to mobile phones, to the internet, to different sources of information, how can we make the information we do have more accessible to different audiences?
I'm going to punt on that. I don't know anything about this.
Okay. Although you could say that your book is a way of making the data more accessible.
People in Tanzania should read my book. I'm sure they will be getting there. It's in a lot of countries. I'm sure we're getting there. Before that, I'll let them answer.
I've seen that same huge expansion of smartphones and just mobile phones in general. Mobile coverage has just increased exponentially in Africa and in other low resource settings. And I have to say, we're not there yet, but there's a lot of conversation going on right now about a Yelp-style accountability for health facilities and health systems. Can we create report cards or scorecards for quality of care? There's a long way to go in terms of defining what quality of care means and making those data accessible to communities. But it's something that people are starting to talk about. Should people in community have the ability to review and post reviews about the kind of care that they receive, their experience of care, the delivery of care, which are the two components of the World Health Organization model of quality. But also even to step back a bit and facilitate the ability of health centers or hospitals to post their own data in a public way, just on a piece of paper. Certain measures that are important to the community, things that they want to know, So in a less techie way to make data about quality of care accessible to communities so that there is some form of accountability and there's a dialogue ongoing about what the outcomes of the facility are.
Yeah, and I'll just add to that. I agree that I think we're still far from having everything be tech-based because it's so different in different contexts. That being said, it is working in some settings, and I think that this dashboard idea, even if it's not a tech dashboard, but some way for facilities to be able to report on their routine statistics, because one of the data gaps, I guess I didn't bring up earlier, but just routine health information systems need to be strengthened in a lot of these settings, and not just that, but the use of that data to kind of reflect on that data. What do these statistics mean in terms of how many ANC visits, how long people are spending with their patients, things like that. But and then being able to review if there's any kind of event that happens, like a maternal death, what happened. I think there are some quality improvement strategies that are being tested in a number of places, and I think they're a good way to start, but still quite a bit more to do.
Okay, so let's take another round of questions. I know I focused mostly on this side of the room, but okay, great. Got one over here.
Hi, thanks so much for letting us bring babies this time. So when I had my first daughter and I was really struggling to breastfeed, I think you read all these studies and a lot of them, they all measure, how many ear infections does your kid have relative to formula feeding. And, it ended up that I didn't breastfeed, and one unanticipated consequence I saw was that my partner had just this huge amount of parenting confidence, and he took our baby on weekend trips, and he could do overnight shifts by himself. And it struck me that that's a super important outcome that I had never seen a study of breastfeeding address, and it's an outcome that I care about. And I'm just curious, what other parenting outcomes really matter but aren't being measured well and are inhibiting our ability to make evidence-based decisions, particularly in line with preferences, which are multidimensional and complex.
Great question. Okay, anyone else? Okay, got one up here.
Thank you. So my name's Aaron. We're expecting our first in October, but we have a bunch of friends with young kids, and some of them are collecting unbelievable quantities of data on every pee and poop and grading it on scales I don't understand and stuff. And I'm wondering whether that data is actually useful or if they're just making themselves feel better.
Okay, I can answer that.
Okay. Anyone else? Okay, great. We've got one more up here.
Hi, I'm Trini. I'm expecting my second. First one was born in Japan, so now I'm experiencing the U.S. maternal healthcare system. So based on that, first of all, thanks for your presentation. It was wonderful. Do you think that actually the segmentation of the U.S. system has an impact on how do we make the decisions and how we actually feel empowered? I mean, right now, because you're checked by a specialist on ultrasound, and then your doctor tells you, I just watched that ultrasound, and then you don't really know the midwives who are going to be with you when you give birth, and then you have you're part of this big practice, not really with one OBGYN who kind of follows you through the pregnancy. And in that sense, thank you for bringing up that building that confidence of between you, but it's kind of hard to build it if you're constantly shifting with doctors. So that's kind of my question.
Great. So should we start with the outcomes that matter, such as partner engagement and confidence, that aren't being measured, and ways to do better in capturing those kinds of outcomes that are more patient-centered and parent-centered?
Yes, this is a problem. There isn't a lot of, the thing that you want about breastfeeding, and which I think is an experience that a lot of people share, we don't have studies that measure that as an outcome, or even more generally, things like marital satisfaction or, even like good evidence on postpartum depression and anxiety, like again, and then when we go into kids, I mean, there's a sort of general issue, which is all of the, like I spent all the time with these studies in the book, and like all the outcomes for kids are like IQ scores and behavior problems and these sort of like measurable things. And somebody once was like, don't we have any studies about whether a kid is nice? No, like, but presumably, like that is an outcome, like that we are, we care about. Like I would like my kid to be nice. I don't just want them to have a high IQ score and not experience a lot of externalizing behavior problems. But those are the only things that we're measuring, and so I think we're up against both sort of limits to measurement. Just there are some things that are easier to measure, but also in the particular case of what you raised, I think we are not, in these early parenting moments, thinking enough about the sort of cohesiveness of like the household and how is the household functioning, and I think we could do better. We could do better there. And I mean, even in the case of breastfeeding, we do sometimes we'll see measures of sort of stuff about the mom, but the idea that somehow this would engage the other partner in a way that is like productive, I just have not seen anything on that, even though anecdotally I hear that all the time.
Yeah, and I think there is a huge. Well, it's not huge enough maybe towards patient-centered outcomes research. It's a thing, PCORI, and probably it needs more funding and more exploration as well, so we get better data around these things.
Yeah, I'll say the same thing. I think qualitatively, but definitely no metrics are still to actually have a set of like indicators or something to measure these types of outcomes that are important are just not quite there yet.
And I think when it comes down to it, we do care about, we want our children to have empathy, but what kind of, parenting, results in children who are truly kind and empathetic, it's hard to say.
Okay, let me break it down for you. No, it doesn't matter. It is not predictable. Like, and I think there's nothing wrong with collecting a lot of spreadsheets about your baby. It's cool. But it does, like, sometimes then you will be led into thinking that there are patterns there which are not there, which is also fine. But I think that the way I put it in the book is like this is giving you the illusion of control rather than actual control. So if you're someone who enjoys illusion of control, this might be for you. But if you are thinking this is gonna like help you, organize your baby, like that's not necessary.
I look back at these diaries that I kept of every single thing my baby ate, and it's like,
why?
Well, no, they're fun to read. They're fun.
That's true.
I mean, it's fun for me to look back on it, and I look back and say, when did he start talking? I think he was this month old, and so I'll look back at some of these things, and they're fun to look at. They're sort of charming to have. I don't know. I don't think that he's healthier or my daughter is healthier because, I took detailed notes on them. It was a way of communicating with caregivers. Like, it was a way of showing my mom and my nanny or whatever, like, can you write down what he eats today or what she eats today? Because I'm interested, And so it's.
But when it's like 18 minutes on this side, 12 minutes on that, like, you're not going to look back on that and be like, boy, I'm really glad I understood that at that moment it was exactly, they nursed for exactly 18 minutes. You're not going to look back on that. You're not going to be happy that you did that.
Yeah.
Later. It's not going to, no.
I will say that when you keep data on a child's illness and write some things
that's
down,
good.
That's the exception. I think when you write down when symptoms first started to appear, take a quick note. Don't make yourself crazy. But that's something that's useful for health professionals. A pediatrician, if you can say, his fever started on Thursday and it went up to 102, like, that's useful information.
And then it came down this much when we gave them like some.
Exactly.
There's like a few things like that when they're sick. But as like a regular.
Routine care.
No. Don't do it. What was our last
So
one?
the last question was about sort of the fragmentation of care, that there's an ultrasound technician and then your physician and then whoever is actually doing the delivery and the extent to which do we have evidence about the impact of that kind of discontinuity across the continuum of care?
So I don't know that I could speak exactly to that, but I think there's definitely sort of in the trust literature, when you're looking at what are the factors that build trust in a health system or with a provider and things like that, I think discontinuity definitely does a disservice. When it's the more fragmented the care is, the harder it is, at least to build trust within an individual provider. That being said, people will also say that they trust the system. So I think there's a slight distinction in how sort of your confidence in the system to provide you care that you need to essentially like make sure there are no problems or be able to mitigate any problems that come through. That's one piece of it. And but if sort of when it comes to the interpersonal doctor-patient relationship, the more continuity, the better. And I think that there's a lot of things that go into what makes that continuity fruitful and the quality of conversations that you have, whether it's mutually respectful, the conversations, whether you perceive the provider as having the knowledge. And part of that might be sharing when they don't have the knowledge. And so it's a much more complicated thing. And so I mean, just to say that I think that it would be interesting to kind of look across health systems to see how this phenomenon is different. And I think there's definitely scales that are starting to be developed and tested across the board to capture something like trust, which is very hard to measure. But I think, again, farther to go. But I do.
I think in the U.S. this is sort of interacting in a complicated way with the health system, because like if you being someone who's going to be present for all of the births of the people that you are treating is
Super
like
hard.
it's like panicking, but it's very hard. I mean, is sort of it, and it also gets in the way of what kind of people are going to want to do this job, right? I mean, if you're in a group practice with a bunch of other people, and it is conceivable, like that's a job that's much more appealing for women. And so when we sort of look at like the influx of women into medicine, I think some of that has been facilitated in this space by having sort of the ability to kind of job split a little bit, and have not have to cover every patient that you have that's having a baby. And so I think that's been that's sort of a challenge for our system, which is different from some other places. But I will say my first kid was delivered by somebody I had never met. It was fine. I mean, it's like it came out.
I've worked under both those kinds of models where you are on call 24/7, and you'll be there for your clients every single antenatal care visit, and you'll be there for the delivery to the best of your ability. And that's really hard. It means it's hard to do once you have kids, which is why I didn't do it anymore after I had kids, because I could no longer promise or guarantee that I would be there for the delivery. At the same time, there was something very special about it. Those are some of my favorite memories of taking care of pregnant women and babies. I think it's because we have so much evidence that we have so much subspecialization. Because there's so much new evidence, people really feel like, due to the litigious environment, they can't do everything. And due to the fact that there's so much to know and do, they can't do everything. And the lifestyle choices. Mm-hmm. But it means that, if I choose to be a midwife or an OBGYN, people don't expect me to be able to also do ultrasounds. You need to do ultrasounds relatively frequently to be good at them. And so just trying to do one once in a while is probably not a great idea. And so having people on the team, a team that you trust and a system that you trust that can bring all the components of care that you need with a level of quality is important.
Yeah, I think we've also been seeing a lot of this sort of knee-jerk response to, well, childbirth has become over-medicalized, and this is such a profound experience in a woman's life. And I know a good colleague of mine essentially spent a couple of years just interviewing women on what a good birth is. And there's a lot of things that make that experience a good or a bad experience. So I think it doesn't necessarily boil down to how fragmented the care is or how large the care team is. I think there were many different things across that for many different people with different preferences. And I think it comes down to, again, having some of these things that indicate what builds a trusting relationship with the system or with the providers that you're interacting with. But a lot of it also comes down to navigating what's right for you. So, I mean, we've seen the increase of like doulas that are supplements to the care team so that you have some sense of continuity across that entire process. But again, I think it really is highly variable for each woman and each family.
Yeah. And I think we are seeing some attention at the global level to global normative agencies. WHO, World Health Organization, now cares about what matters to women when they're writing new antenatal care, intrapartum care guidelines. And so now part of the evidence review really is about what matters to women. So I was part of the Antenatal Care Guidelines Committee for WHO in 2016, And we thought we were just going to see the results of a bunch of studies, a lot of tables, like look at a lot of data for 3 days straight. And we were really surprised to see a whole presentation on research that had been commissioned and done on what matters to women in prenatal care as part of the evidence and review and the generation of recommendations.
So are there any last questions before we turn over to some snacks and book signing? Going once? Ah, great, one over here.
It'll be a quick one and hopefully a good wrap up. I'm Sarah, this is Kieran. I wanted to reiterate what another one of the women said, to thank you for allowing children. You know, I'm on maternity leave, wouldn't have been able to come if not for that. So my question generally is, how do we help to make that happen more? How do we get more events that are like this, where you can come in and out, you can have your kids there, they can make a little bit of noise and it's fine? And have you seen any good models that are really, welcoming to parents of all sorts to come and bring their families?
This is the first event I've been to like this, Carly. So congratulations to the center for actually having an event like this.
And we're so thrilled that people brought their children, that they could attend in person because of this. I mean, I don't know that we've seen a lot of other models that just seem like, given the topic, it would be crazy not to allow people to bring their children so that they could participate. But I think that, it's a good question to ask, why don't we do this on all kinds of things that people might want to attend when they're, on their maternity leave, where they do want to learn about whatever topic it is that we're hosting here. So maybe it's something that our events team can talk more about. I mean, we don't have a policy that says you can't bring your children. We just don't often advertise it in the same way that we did for this event.
But I also think we can, if you just there's this sort of do it and then realize that it's okay. Do you know what I mean? People are like, oh, if they're babies, they'll make some noise, and then that's fine. Just keep talking. And so I think that the more we can kind of normalize the same way you try to normalize it at work. It's just yes, a lot of people have babies. That's how we get more humans. At first they start as babies, and then we just hide them away until they're able to participate in the discussion. I think that would be best, but just doing it.
Great. Well, thank you all so much for coming. Thanks to our panelists for joining us today. There are refreshments outside. Emily will also be signing books, which are available for sale in the back. And feel free to stick around and have a chat with any of us. Great. Thank you so much.